Hi, today I'm going to present an interesting case of a neglected elbow dislocation. So here we have a 30-year-old farmer who had a dislocation of the left elbow for which he underwent a close reduction and a slab application. However, the elbow dislocated within the slab which the patient ignored. When he presented to us, it was 3 months since the dislocation. In the image, you can see a posteromedial dislocation of the elbow with no obvious fractures. On presentation, he had a elbow range of motion of around 60 to 100 degrees with a lot of pain. While his supination and the pronation on the left side was terminally restricted, associated with pain. MRI that was done showed the dislocation along with severe synovitis in the elbow joint. So this falls under the classification of a chronic persistent dislocation of the elbow. In the literature, there are no clear-cut guidelines of what would be the ideal management. However, the treatment depends upon the joint status and the duration since dislocation. So the options include just a close reduction with KOR or an external fixator, or just reduction and a slab, or open reduction and a ligament repair, which is what was done for this patient. Our goal in this patient was to get a perfect joint reduction and reconstruction of LUCL and anterior medial collateral ligament to provide stability. So our technique involves first to harvest the Gracilis graft from the knee joint. So on the graft we have a leading and a trailing end. So trailing end we anchor an endo button, and now we move attention to the elbow. We place the patient on the lateral decubitus position and I use the universal posterior approach to the elbow. Here we dissect the ulna nerve and we remove all the scar tissue and synovitis so that we get a proper open reduction of the elbow joint. We make sure that we have a proper alignment of the radiocapsular joint, which is easily visible. We check the elbow on the image intensifier to confirm the reduction. Even though we have a congruent joint here, there is some ulnohumeral sag suggestive of a incompetent ligamentous support. So our technique of ligament reconstruction begins with making 3 drill holes with a 4 mm cannulated drill bit. First one is through the interapical region of the distal humerus. The second one is from the footprint of the LUCL, transversing it distally and obliquely. And the third one is through the footprint of the anterior medial collateral ligament and transversing it distally and obliquely. Then we take the Gracilis graft, the leading end, and pass it out through the footprint of the LUCL and take it out into the distal humerus. We hold the graft tightly, maintaining the tension and pronation, and insert an interferential screw on the lateral side. And then we take the loose end of the graft and bring it out through the footprint of the anterior medial collateral ligament and pull it hard, maintaining the tension and supination, and anchor it either with another screw or an endo button. Here we can see the tightness and the position of the graft. anchored with the interferential screws. So we always check the stability intra by doing range of motion and recheck on the image intensifier. Here we don't see the ulnar humeral sag anymore, suggestive of a good ligamentous reconstruction. Whenever there is a suspicion of a ligamentous laxity, it is recommended to use the external fixator to provide additional stability. Our post-op protocol involves immobilization in a slab in mid-prone or a prone position for 2 weeks, and then be followed by overhead range of motion from 90 degrees to further flexion towards the gravity, and at 6 weeks we remove the splint and allow for complete extension and flexion. This is a radiograph at 8 weeks showing us a congruent elbow joint with the position of the endo buttons. At 3 months, the patient has a complete flexion and extension of the left elbow joint. And this is this pronation and supination, which is complete and painless and is comparable to the opposite hand. Our technique has been described in this article. I thank you for watching our video. Have a good day.